Imagine for a moment that the human body is this high-performance engine.
Right.
It's designed to run at a specific temperature, maintain specific pressure, and just hum along in this perfect state of balance. But what happens when you overheat it?
Or cut the fuel line.
Exactly. Or when a piston just wears out and stops firing.
That is where the engine breaks. And looking at that breakage, understanding the specific mechanism of the wreckage, that's exactly what pathology is.
It's not just naming a disease.
No, not at all. It's about understanding the story of how the body failed.
Today, we're not just looking at random diseases. We're doing a comprehensive medical review based on what many, many medical students consider the absolute Bible of the subject.
Oh, for sure.
We're doing a deep dive into Fundamentals of Pathology by Dr. Hussein A. Sattar.
This text is, well, it's legendary in medical education for a reason. Dr. Sattar's philosophy is very specific. He values concepts and principles over just memorizing random facts.
He wants you to see the forest, not just the trees.
Precisely. The idea is that if you understand the mechanism, you don't have to memorize a long list. You can actually derive the answer.
So our mission today is to take that high-yield approach. We're going to walk through the general principles of how cells get injured and die, and then apply that logic to specific organ systems.
Whether you're a student prepping for step 1, a professional brushing up, or just an enthusiast, this is for you.
We're going to keep it systematic. Let's start at the cellular level.
The foundation.
Let's unpack that. The cell. Dr. Sattar makes a really interesting point right at the start. He says cells are constantly trying to stay in a steady state, right?
Correct. We call that homeostasis. The cell is happy, it's balanced, but disease begins when you apply stress that exceeds the cell's ability to adapt.
And bills are smart.
They are. If you stress them, they try to change to handle it before they just give up and die.
This is where we get into those terms that sound similar but are really different. Hyperplasia and hypertrophy. I always think of the gym here.
Good enough.
If I lift heavy weights, my muscles get bigger. That's hypertrophy, right?
Precisely. Hypertrophy is an increase in the size of the cell. You're activating genes, synthesizing proteins. The cell is bulking up to carry a heavier load.
Okay, but then what's hyperplasia?
That's where an organ gets bigger because the cells are actually multiplying. Hyperplasia is an increase in the number of cells.
So do they usually happen together?
Often, yes. A perfect example is the uterus during pregnancy. It undergoes both hypertrophy and hyperplasia. It needs bigger cells and more cells.
Wow.
But, and this is a critical high-yield concept, there are certain tissues in the body that cannot make new cells. We call them permanent tissues.
Okay, so these are the parts of the body that once they're built, that's it, no new recruits.
Exactly. Cardiac muscle, skeletal muscle, and nerves. They lack stem cells.
So what does that mean in practice?
Well, if you have high blood pressure and your heart is working overtime against that resistance, the heart muscle cells can only undergo hypertrophy. They get bigger, but they can't multiply.
Which explains why heart damage is so permanent. You can't just grow new heart muscle.
You can't.
Now, what about when a cell decides to just change its identity completely? I was reading about Barrett's esophagus in the text.
That is called metaplasia. It's when one cell type is replaced by another that's better suited to handle the stress.
It's like a tactical substitution.
A reprogramming of stem cells, exactly. In Barrett's esophagus, you have stomach acid splashing up into the esophagus.
From acid reflux.
Right. And the esophagus is normally lined with delicate squamous epithelium. It can handle friction, but it cannot handle acid.
So the body swaps them out.
It does. It swaps them for columnar cells, basically, stomach-like cells, because they can handle the acid. It's a survival mechanism. But there is a catch.
There's always a catch with the human body.
Metaplasia is reversible if you remove the stress. But if that stress persists, metaplasia can progress to dysplasia, which is disordered precancerous growth, and then to cancer.
So it's a warning shot. Fix this or else.
Exactly. And on the flip side of growth, we have atrophy.
Where cells shrink.
Right. Due to disuse or lack of nutrients. The mechanism Dr. Sattar highlights here is fascinating. It's the ubiquitin proteasome pathway.
So what's that?
Basically, the cell tags its own internal skeleton with a protein called ubiquitin.
It's like putting a trash sticker on your own furniture.
That's a perfect way to put it. And then a structure called the proteasome comes along and destroys it. The cell essentially eats itself to survive.
Okay, so those are adaptations. The cell is coping. But what happens when adaptation fails?
Then we enter the territory of cellular injury. The hallmark of reversible injury is cellular swelling.
And that comes from?
Usually from hypoxia, low oxygen. Low oxygen means the cell can't make ATP. Without ATP, the pumps that keep sodium out of the cell fail. Water follows sodium, and the cell just swells up.
But at that point, you can still save it.
Yes, but if the damage creates holes in the cell membrane, that's game over. That is irreversible injury. Calcium rushes in, enzymes leak out, and the cell dies.
And Dr. Sattar distinguishes between two very different ways a cell can die: a messy way and a clean way.
Right. The messy way is necrosis. This is murder. Death of a large group of cells, and crucially, it triggers acute inflammation. The cell spills its guts, and the immune system rushes in.
And the clean way.
Apoptosis. Programmed cell death. The cell shrinks, breaks into tidy little packets, and is quietly removed. No inflammation.
It's like a controlled demolition versus a building collapsing.
Perfect analogy.
Let's talk about that collapsing building necrosis. The text lists specific patterns that tell you how the tissue died. It's almost like forensic science.
These patterns are diagnostic gold. The most common is coagulative necrosis.
Right.
This happens in ischemic infarction, loss of blood supply to any organ except the brain. The tissue remains firm, the cell shape is preserved, but the nucleus is gone. It looks like a ghost town under the microscope.
You mentioned except the brain. Why is the brain different?
The brain undergoes liquefactive necrosis. It's rich in enzymes from microglial cells, and it lacks structural proteins, so an infarction there just turns the tissue into a liquid viscous mass.
It literally liquefies.
It does. It's a vivid image.
What about caseous necrosis? The text describes it as cottage cheese-like.
That is the classic description. It's soft, friable. You see this in tuberculosis or fungal infections.
And then there's fat necrosis.
Which is exactly what it sounds like. Trauma to fatty tissue like the breast, or enzymes from an inflamed pancreas break down fat. The fatty acids then bind with calcium to form chalky white deposits.
That's called saponification, right?
It is. It's essentially soap formation inside the body.
Soap in the body. That is wildly fascinating and slightly disturbing. Okay, let's move to the body's response to all this damage. Inflammation.
Inflammation is the body's double-edged sword. Acute inflammation is the immediate response. The key player here is the neutrophil.
The first responders.
Exactly. They rush in to eliminate pathogens, clear debris. This is where you see edema fluid leaking out of vessels.
But if the problem doesn't go away, it becomes chronic.
Correct. Chronic inflammation is a delayed response with lymphocytes and macrophages. A specific high-yield type is the granuloma. This is where macrophages wall off a pathogen they can't eliminate, like in TB.
They build a prison around the bacteria.
They do. Now, eventually things have to heal. The book talks about regeneration versus repair. Regeneration is getting your original tissue back. Repair is scarring.
And there's a specific pathology Dr. Sattar highlights, the keloid.
Yes, a keloid is scar tissue that grows way out of bounds. It's an excess of type 3 collagen. It tends to affect earlobes and the upper extremities, and there's a genetic predisposition, particularly in African Americans.
Is healing that doesn't know when to stop. Moving on to neoplasia, cancer. What's the fundamental definition here?
Neoplasia means new growth, but specifically, it is unregulated, irreversible, and monoclonal.
Monoclonal, meaning it arises from one single mutated cell.
Exactly. And the big distinction is benign versus malignant. Benign tumors stay put. Malignant tumors invade and metastasize or spread.
Let's switch gears to the plumbing hemodynamics. Clots. Why do they form when we don't want them to?
We look at Virchow's triad. There are 3 risks. 1, disruption of blood flow. 2, endothelial damage to the vessel wall. And 3, a hypercoagulable state.
And there's a really cool forensic detail about telling if a clot happened before or after death.
The Lynsazon. These are alternating layers of platelets, fibrin, and red blood cells. You only get these layers if blood was flowing when the clot formed.
So if you see lines is on,
the patient was alive when that thrombus formed. If you don't see them, it was likely a post-mortem clot.
Incredibly useful. And if that clot breaks off and travels,
it becomes an embolus. Most are dislodged thrombi, but you can also have a fat embolus from a bone fracture or an amniotic fluid embolus during labor.
Okay, we've got the toolkit. Let's do what Dr. Sattar does so well and apply this. We're going to do a rapid fire round through the systems. Ready?
Ready. Let's go.
Vascular pathology. Vasculitis. What's the one we cannot miss in an elderly patient with a headache?
Temporal arteritis or giant cell arteritis. Usually elderly females, they get a headache, maybe jaw pain, visual disturbances. The risk is irreversible blindness.
So if you suspect it,
you treat with corticosteroids immediately. You do not wait for the biopsy results. Saving vision is the priority.
Next, the heart. Endocarditis.
Inflammation of the heart valves. If it's an IV drug user, the bug is likely Staphylococcus aureus. Highly virulent, destroys the valve. If it's someone who just had a dental procedure, think Streptococcus viridans. Less virulent, attacks already damaged valves.
Moving to the GI tract. Ulcerative colitis versus Crohn's disease. How do we keep them straight?
Location and depth. Ulcerative colitis, or UC, starts in the rectum and moves back continuously. It's superficial. It looks like a lead pipe on imaging.
In Crohn's.
Crohn's can happen anywhere, mouth to anus. It has skip lesions, and the inflammation is full thickness, leading to knife-like fissures. The mucosa looks like cobblestone.
Okay, sticking with the gut. Hirschsprung disease in kids.
This is a failure of development. Neural crest cells fail to migrate to the rectum, so the baby is born without the nerves needed to relax and pass stool. Causes a massive obstruction.
Associated with Down syndrome.
Notably, yes.
Let's jump to endocrine. Thyroid.
Two major players. Graves' disease is hyperthyroidism. An antibody stimulates the thyroid. Patients get bulging eyes, exophthalmos. Then there's Hashimoto thyroiditis, hypothyroidism, autoimmune destruction of the gland.
And diabetes. Type 1 versus type 2. What's the pathology in the pancreas?
In type 1, the immune system just destroys the beta cells. In type 2, linked to obesity, the beta cells get exhausted. You actually see amyloid deposition in the islets of the pancreas.
Central nervous system.
Yeah.
Patient comes in yelling about the worst headache of my life.
That phrase is a classic red flag. It should scream subarachnoid hemorrhage, usually a ruptured berry aneurysm at the base of the brain.
And Dr. Sathar mentions that fascinating link between Alzheimer's and Down syndrome. Why did they get it so early?
It comes down to gene dosage. The gene for amyloid precursor protein, APP, is on chromosome 21.
And Down syndrome is trisomy 21.
Right. 3 copies of that chromosome means more copies of the gene, which means more amyloid production. This leads to those plaques developing much earlier in life, often by age 40.
A perfect example of mechanism explaining disease. Finally, skin.
Let's touch on pemphigus vulgaris. Autoimmune destruction of desmosomes, the spot welds holding skin cells together, causes blistering.
And tumors.
Basal cell carcinoma is the most common skin cancer. Presents as an elevated nodule with a central ulcer, usually on sun-exposed areas.
Okay, we have covered a massive amount of ground.
And this brings us back to the core philosophy. Pathology isn't a list. It's a study of mechanisms. If you understand how a cell gets injured, you can predict what the organ will look like.
Let's put that to the test.
Uh-oh.
I'm going to pose a scenario based on the text.
Go for it.
You have a patient who has passed away. On autopsy, in the kidney, you see a pale, wedge-shaped area of tissue. It's firm. Microscopic exam shows dead cells, but the structural outline is preserved. What is the diagnosis and what caused it?
Okay, let's connect the dots. First, the tissue is firm, architecture is preserved. That tells us this is coagulative necrosis.
Right. Not liquid like the brain.
Exactly. Second, the shape. It's wedge-shaped. That points to the blood supply. The kidney has end arteries that fan out, block one, and the tissue downstream dies in that wedge shape.
So the final call.
The diagnosis is an ischemic infarction of the kidney leading to coagulative necrosis. The cause was likely a thrombus or embolus blocking a renal artery.
See, when you break it down like that, it's logic. The wedge points to the crime scene?
Exactly. And that is the power of understanding the principles. You aren't guessing. You're deducing based on the laws of the body.
We've thrown a lot of information at you today. This material is dense, but it really is the foundation of medicine.
It is. And Dr. Sathar closes his book with a reminder that I think is vital. He says, our goal is to learn, to share, and to serve.
That's a great perspective. All this knowledge, the necrosis, the syndromes, it's weightless until you apply it to help a human being.
Right. We study the mechanism so we can intervene in the suffering. That is the ultimate goal.
So keep reviewing those notes in the margins. There's always more to uncover.
Indeed. Until next time.
Thanks for listening to this deep dive.